Hello, hello. Welcome everyone. Happy Wednesday morning. It's still morning here on Central Time, Texas time. My name is Hiva Kolodrobitz. I'm a family nurse practitioner here with Archer Review. And this morning I have a really fun webinar set up for you guys talking about the thyroid gland. If you join me on TikTok or Instagram Live this morning, we went over some practice questions. We're going to reiterate those practice questions throughout our presentation today. I'm going to give you a lot of content around those practice questions, and then we're going to end with a fun little case study. So my goal is to help you learn something, walk away with having learned something new today, not just for if you're practicing for your boards or sitting for your board soon, but really for clinical practice. So that's why we work in those case studies, because the best way to get that practice with prescribing is to really continue to practice it in a case-based scenario, right? So before we get started, I like to have everyone use this Slido tool. If you've joined us for one of our webinars in the past, you've used Slido, maybe you've used it in a different context, but I really like Slido because it helps me engage with you. It helps you interact with me without feeling self-conscious. So there's a level of anonymity there. You can participate. It doesn't give you a name of the participants, and it just shows you what your response was compared to your peers. So it's a really nice way to engage and interact and feel less self-conscious about it when you're on a public platform like this. So if you've used it before, you know you can scan this QR code and it'll go to slido.com. If you don't like to do it on your phone and you want to keep it on your computer screen, you can just go to slido.com and put in the hashtag thyroid review. That should be sufficient to get in there. And if you go, the first poll is already launched for you. And I'd love for you guys to play around with this before we get into the content, just so we can all get really comfortable with Slido. So I just have some opening Slido polls in there just to get to know my audience, see who's in the audience today. So go ahead and tell me who's in the audience. Are you a registered nurse? Are you a nurse practitioner student? Are you thinking about NP school and that's why you joined us today? Are you ready to wrap up NP school and you're getting ready to take your boards exams and enter clinical practice? Tell me where you are in your what we call the lifespan of the nurse. So myself, I am a family nurse practitioner. I've been practicing as an NP for 10 years now. I've done primary care, I've done specialty, including endocrinology and cardiology. Those are my two loves. And now I'm back to primary care an employee health clinic, which is really nice to kind of round it all back to primary care. And I'm really grateful that I had that foundation in primary care to really be able to do that. So I see some FNPs in the audience. Welcome. I see someone just finished NP school. Awesome. Are you getting ready to sit for your boards? Have you already taken your boards exams? Which board exam are you thinking about taking? You can put in multiple responses, and I want you guys to get used to this poll because as we get to the case study, this is called an open text poll. You can really put in multiple responses, and I'm going to ask you for that. Like when we're talking about the assessment, diagnosis, what should we order in the labs? What are you going to prescribe, right? So I want you to get used to this Slido tool. And if you missed that QR code, it's down here too. You should be able to see it. And again, you can go to slido.com and put in the hashtag if you can't get the QR code to scan for some reason. So looks like we have a few NPs getting ready for ANCC, NP student in the audience. Very good. So yeah, ANCC is the one I took, and I remember getting ready for your boards, trying to decide which boards, a date. So definitely want to make sure, and I know your schools have probably advised you as well, making sure that you sign up for a date soon so that you're more likely to retain the information that you've been studying is really important. And so you guys can keep typing. RN for 16 years. Awesome. Very good. Beautiful. I love that. And so maybe considering NP school. And I see some typing. So you guys getting used to this Slido. Awesome. So we're going to go to our next poll, and I want to see where you're logging in from. So oftentimes we get students from all over the US, which is awesome. We also get some international students, which is really cool. So I try to really think about that when I'm putting these presentations together about what may be relevant to everyone, right? Not just us here in the States. So that's really cool. In NP school in Florida, we have some people from Connecticut. I'm in Texas right now. That's where I've been practicing for the last more than 5 years, actually. But I'm originally from Massachusetts. I've also practiced as an NP out in California, so we've moved around a lot. So I see a fellow Texan here in Houston. I'm in Dallas. Welcome. And looks like mostly domestic RNs and NPs on the webinar today. Okay, so this is called a word cloud. You guys are probably familiar with word clouds. I really like them because as more people put in the same response, it gets really big. So we'll see some word clouds too when we're doing our polling. Okay, so let's get into the real content. You guys are all really comfortable with the Slido tool, I can see. So let's get into the content, and we'll be using that Slido. So keep it pulled up. We'll be using it throughout today's presentation. So before we get into the pharmacology, I always like to do a quick anatomy and physiology review. You really can't understand the pharmacology on a deeper level until you understand what's going on with the normal anatomy, physiology, and then the pathophysiology, right? The abnormal. So remember, when we're talking about the thyroid gland, we're talking about its main function. And what is its main function? It's producing those thyroid hormones. That's your T4 and your T3. Remember, T4 converts to T3, but those are your main thyroid hormones. And your body is continually assessing the level of thyroid hormone and signals back to the pituitary gland to release or suppress that thyroid stimulating hormone. So that's actually coming from outside of the thyroid. And just like its name, its real purpose is to stimulate that thyroid to either produce more thyroid hormone or to pull back and not produce, not release as much thyroid hormone. So that's really important to understand because oftentimes, remember, patients are not medically trained. You might be taking care of some medical providers. That was my first job as an NP in internal medicine. It was really intimidating because I was taking care of really seasoned nurses and physicians. And so they knew more than I did. I really had to step up my game. But for most of the time, our patients are not medically trained. So they'll come in, and now with patient portals, they get everything, right? And so they'll come in and be like, hey, I thought I had a sluggish thyroid. I thought I had a thyroid that didn't work as well. How come my TSH levels are through the roof? So you really have to understand what's happening as a clinician and be able to educate your patients to know that that thyroid stimulating hormone, that TSH, is actually coming from the pituitary gland, and its purpose is to stimulate that thyroid and get that thyroid gland to produce the thyroid hormones T4 and T3. So this is going to help you as well when you're interpreting your labs, when you want to make the diagnosis and you're managing patients on these medications. Okay, so first and foremost, let's talk about hypothyroidism. So remember, you have two different types of hypothyroidism, primary and secondary, and we'll get into that in a little bit. But what's happening in hypothyroidism is that you're getting an underproduction of those thyroid hormones, that T4 and T3. So it's just not enough in the bloodstream, right? Your body has detected that, and so it's signaling to the pituitary gland. The pituitary gland is signaling to the thyroid, we need more thyroid hormone. So you're going to see elevated or higher levels of that TSH, that thyroid stimulating hormone. Now, primary hypothyroidism is when the problem is from the thyroid itself. It's happening within the thyroid. And secondary hypothyroidism is when the problem is coming from outside of the thyroid. And so typically, what we will manage in primary care is that primary hypothyroidism. And you have a lot of different types of primary hypothyroidism. You have Hashimoto's, iodine deficiency, surgical, right? If they have, maybe if they had hyperthyroidism or a nodule and they had to remove part of their thyroid gland, they now are hypothyroid, right? And will require medicine to reach those right levels of thyroid hormone. Same with the radioiodine, if that was the treatment that was recommended, and now they have primary hypothyroidism because of cancer or nodules or whatever they need to treat, and radiation to the head or neck can oftentimes damage the thyroid gland as well. So those are all causes of primary hypothyroidism. And secondary causes, again, happening outside of the thyroid gland, most typically is a tumor of that pituitary gland or the hypothalamus. And that's really something that's going to be managed by an endocrinologist. We're really looking at that primary hypothyroidism. So I'm going to launch my next poll. Which is the most common cause of primary hypothyroidism in the US? And the reason why I'm asking and the reason why we're discussing this today is because sometimes this might pop up on the boards. And why would the boards ask you something like this? Why do they care, right? Well, they want you to dig a little deeper. When you're diagnosing someone with hypothyroidism, they want you to be thinking, is this primary? Is this secondary? And what type of primary are we looking at, right? What is going to be the most common in the US? And it looks like you guys are weighing in. I see a couple people thinking about it. But what do you think? Is it Hashimoto's or iodine deficiency? Out of the two, which is the most common here in the US? Or we can even say the Western Hemisphere. Yes. So Hashimoto's, that autoimmune thyroiditis, is the most common in the US. So when you're looking at patients, you've diagnosed their hypothyroidism, once you get really comfortable, you can start ordering those thyroid antibodies, especially if they have a family history, they have other autoimmune conditions. You might want to go ahead and get those antibodies as well to confirm that this is Hashimoto's. Awesome job, you guys. Iodine deficiency, for those of you who are not in the Western Hemisphere, iodine deficiency is the most common globally, but here in the US, it's Hashimoto's, is the autoimmune, because we get enough iodine in our diet for sure. So common signs and symptoms, universal signs and symptoms. You might get patients coming in saying they're just really tired all the time. That's a very vague and generic symptom, and it's really hard to figure out what's going on with the patient when they come in with the chief complaint of fatigue. And we'll go over that in our case study today. But they might say, yeah, I'm always tired. I just can't seem to get enough energy. I just feel like my brain is just foggy. I'm not functioning properly. We call that brain fog due to thyroid dysfunction. It is actually very common because thyroid hormones are really important for cognitive health. So we do see that. They might also report constipation. And so this isn't like constipation once here, once there. This is really chronic constipation where they need some over-the-counter additives to really get a bowel movement. This is severe constipation. We see that a lot with severe hypothyroidism. Dry skin, brittle, thinning hair, that can also happen over time with long-term untreated hypothyroidism. Weight gain, another really vague one, right? We get a lot of patients coming in and be like, can you check my thyroid gland? I just can't seem to lose weight. And it's a valid concern, right? And we should be thinking thyroid is one of our lists of differentials, and we want to rule it out. But typically with the weight gain, I really don't see huge issues with weight gain or weight loss with patients with thyroid dysfunction, but it does make it a little bit harder with those patients. But then once you've diagnosed it and you're treating it, patients expect these huge changes in their weight, and we don't see that drastic change with the weight loss once they've been diagnosed, but it can make it tougher. Anxiety or depression. So oftentimes this one goes unmissed. And I really want you to be thinking about it when you have a patient who's coming in with these vague symptoms. They're also anxious, depressed. Anxiety, depression can also cause these symptoms, right? But we want to be making sure that we're not missing an underlying thyroid dysfunction. So when we have a patient, we're talking to them about anxiety, depression, we always want to make sure we're ruling out thyroid dysfunction, because absolutely this is one of the universal signs and symptoms. Heart palpitations, sometimes, yes, you'll get some arrhythmias, maybe with severe thyroid dysfunction. Sensitivity to cold temperature, yes. Slow growth and delayed delayed puberty. These ones are big red flags in our pediatric patient population. We do not want to miss thyroid dysfunction in our pediatric patients. Thyroid hormones are a huge component of achieving normal growth and development. And so we want to make sure if we're seeing those drops in those growth curves, we're seeing delayed puberty, we are ruling out thyroid dysfunction, right? We want to ask those questions and really figure out, is this an underlying thyroid issue? Now with the diagnosis, what are we ordering? We're ordering that thyroid panel. Remember, we talked about the anatomy and physiology. We're looking at that TSH, and the free T4 and the free T3 is going to be our best way of really diagnosing this. What happens? Who knows the difference between overt and subclinical hypothyroidism? When do you treat? When do you not treat? And I guess we could put it, I should have entered a word cloud for this next round. So you can also put it in the chat for me. It's just me today in the chat, so I like to use Slido, but you guys can always put anything in the chat and I'll try to take a look at it as we're talking. So with overt hypothyroidism, we really are seeing some classic clinical features, and we're seeing that elevation in the TSH. So what is that elevation mark, right? It really has to be over 10. And we sometimes will see those low levels of thyroid hormone, typically with T4 first. T3 gets pretty preserved until the end, but we'll normally the classic symptoms or classic labs for overt hypothyroidism is going to be that elevated TSH over 10 and then low levels of T4 with normal levels of T3. Now, subclinical, oftentimes this might happen if you're doing routine labs and you're throwing in a thyroid, or patients do come in with maybe some signs and symptoms, but it's always vague, like with a little fatigue, a little bit of weight gain. And their thyroid levels are elevated, but not to the point where we would really treat. We call that subclinical because it's still kind of like a watch and wait period. We see their thyroid levels are not really, maybe they're around 7 or 8, and then their thyroid hormones are still well preserved. They're in that normal range for that T4 and T3. And maybe they're asymptomatic, maybe they have some symptoms that are vague. This is really subclinical. I see a lot of endocrinologists checking for that thyroid peroxidase antibodies if they have a family history, if they have some vague symptoms, the TSH level is a little bit elevated, they're in that subclinical. I have seen some endocrinologists treat to see if the symptoms would improve. Oftentimes it does not change their symptoms. So best clinical practice is if they're in that subclinical stage, we're just going to watch and wait, right? We're not going to be treating these patients until they're really overtly showing signs and symptoms of hypothyroidism and they have an elevated TSH over 10 with those low levels of thyroid hormone. So that's good for us to know just because we want to be practicing best evidence-based practice in medicine when we get out there, right? Now with treatment, how do we treat that the low levels of thyroid hormone? Well, we give synthetic thyroid hormone, right? So T4 is thyroxine. Its generic name is levothyroxine. Its brand name is Synthroid. We will start patients on this, always start low and go slow. This is age and weight specific. However, you would always start a patient on a low dose because you don't want them to become hyperthyroid, right? So we always want to start low, see how their body responds before we go a little bit, before we titrate up on that medication. So be really careful about this when you're starting patients on thyroid medication. We do want to adjust the dose, so we're going to be having them come back, do labs before their next visit in about 6 to 8 weeks. Here I wrote 4 to 8 weeks because the endocrinology team that I worked with liked to do it about every 4 weeks, once a month. Again, clinical practice says 6 to 8 weeks, so you will use your best judgment, but always practice best evidence-based. You have to really give the medicine time to work. So 6 to 8 weeks is best, and then you want to check those labs again, and then adjust the medication gradually and recheck in another 6 to 8 weeks to see what the final dose is going to be. And then we always want to counsel patients on taking this medication. We'll talk a little bit about that. And with our pregnant lactating females, we may have to be a little bit more diligent about getting them in sooner and increasing and titrating that dose a little bit faster. So that's where really that 4 weeks comes into play. And that's why I left the 4 weeks in there. And who can tell me, you guys can put in the chat, but why do we want, why are we going to be a little bit more aggressive with checking these labs in our pregnant patients? What happens really between that first and second trimester? Do you guys know? You guys can put it in the chat for me. Yeah, and so this is going to be a tough one too. So we're going to try to add a lot more OB type information in these webinars as well as just we have OB in our Q bank, but I just want to bring more OB into the webinars because you guys asked for it and I want you guys to get that information as well. So in a pregnant mom, remember those first 12 weeks, baby's not really producing its own thyroid hormone. So it's going to require a lot more thyroid hormone from mom to meet those baby's demands, right? So we want to be really careful in those first, second trimester to make sure we're watching those pregnant moms a little bit faster or more diligently, more closely to titrate their dose up a little bit faster. So this is absolutely something that you'll be co-managing with endocrinology in our pregnant moms. And we want to make sure we're supporting that fetal growth. And so we want to make sure that we're checking to see if there's enough thyroid hormone for that fetal growth. So we're going to be a little bit more aggressive there. Okay, awesome job. This is also a new slide I'm kind of testing out. We're putting together a pharmacology course for you guys, including pathophysiology and pharmacology. And so I just want to test out how it looks and how it presents, but we kind of already touched on a lot of these things. So we talked about the generic and brand of that T4. There are also different combinations that come with T4, T3. Again, this is something that I see more specialists using. I do caution you guys to not just put people on T3 just to help give them a little bit more energy. I see that being happening out in the clinical world. Please don't do that. There's no evidence supporting that. But really with our thyroid replacement, we are treating that hypothyroidism, right? We see it in the labs and we are treating something specific that we're seeing in the labs to get them to that euthyroid state. This is just a replacement of that thyroid hormone. We talked about that it's synthetic T4. And what we want to watch for is that hyperthyroid state, right? That's what we're starting low and going slow. But if we want to ask patients how they're tolerating it when they come back in for the visit, are they getting increased fatigue, right? Because they're getting more anxious and palpitations. Maybe we're over treating and we need to pull back a little bit. We have to be mindful of that. There are also some contraindications and monitoring parameters around patients who have underlying cardiac issues. So we want to be thoughtful about that as well. But the biggest thing that you might see in primary care boards types questions is really the education piece, how to take this medication. Remember, levothyroxine is best absorbed in a acidic environment in the stomach. So you really want to caution patients to make sure they're avoiding anything that affects that acidity and separating it by at least 4 hours. They do want to take levothyroxine on an empty stomach. So ideally 30 to 60 minutes before breakfast or at the very end of the day, separated by at least 2 hours after dinner. 4-hour separation between levothyroxine and any other medications that do affect the acidity like PPIs or calcium or iron. So definitely some things to be thinking about and watch for as we continue to build out some coursework for you guys here at Archer. All right, I'm going to launch our next course in case you read a little bit faster than I do, and then I'm going to read it with you guys. So you have it right there. So if you're still on Slido, you can go ahead and answer, but let's read it together. A patient has been diagnosed with hypothyroidism and the nurse practitioner is beginning levothyroxine Synthroid 25 micrograms. In review of the patient's current medications, which of the following will require specific education for use concurrently with the levothyroxine? Is it A, B, C, or D? Go ahead, put your answer in the Slido poll, and then we'll talk through it. What do you guys think? Which of the following requires specific education if you see that your patient's taking this medication's on their med list What did we just talk about? Okay, I see a couple responses, maybe the Lipitor, maybe the omeprazole, maybe the escitalopram or the lisinopril. Okay. So if you said A, you absolutely got it right, that PPI. Remember, Synthroid, it needs to be in an acidic environment for us to get the full absorption of it, right? And what do PPIs do? PPIs are intended for reflux. The entire purpose of a PPI is to really reduce the acidity. And so if that's happening, it's really going to affect our absorption of levothyroxine. So we have to be really careful. If patients are on this, we definitely want to counsel them on separating it by 4 hours. Lipitor, escitalopram, lisinopril, these medications don't really affect the acidity of the GI system of the stomach, so you don't have to be separating it by 4 hours. Good rule of thumb, I always like to tell patients still take your levothyroxine on an empty stomach and wait about 30 to 60 minutes. And you can take the rest of your medication with your breakfast or whatever you're eating. So you don't necessarily have to separate it by 4 hours, but I still, a good rule of thumb, want that levothyroxine on an empty stomach. Awesome job, you guys. All right, let's go to the next one. So here is the answer that we just talked through. And again, they gave you a lot of juicy information, right? They told you the diagnosis with hypothyroidism. They said you were starting the levothyroxine, and then they said, what do you want to counsel this patient on? So you might get a lot of questions like that where it's talking about administration, because we really should be slowing down and talking to our patients about how to take their medication so that it's the most effective, right? All right, next poll. I'm going to launch it in case you read faster than I do. We'll go to our next one. And this one, it all fit onto the Slido, so we can stay on Slido. Okay, so the nurse practitioner knows that congenital hypothyroidism must be identified quickly after birth to prevent irreversible neurological effects. Which of the following is the standard of care that has helped identify the diagnosis early? Is it A, B, C, or D? What do you guys think? Go ahead and answer in my poll. So are we going to be how are we going to be screening for this congenital hypothyroidism? Remember, the screening is going to be important. And this is typically standard of care, but we'll talk about this as well, depending on your state. I see some people are thinking about it. All right, awesome job, you guys. The majority of you got it right. So it's that newborn screening, right? So what's happening in every state is we have screening tests that are state mandated and state run. And so with these newborn screenings, every state does it a little bit differently, but ideally within 24 to 48 hours, most, if not all states are screening for metabolic, endocrine, hemoglobin, any of those disorders so that we can intervene early. Remember, anytime in pediatrics we're doing something multiple times, it's to catch it early so we can intervene early to really support the growth and development of that child. So, most states, it is a state-run healthcare initiative, but most states in their newborn screening will screen for congenital hypothyroidism. And so that's why C was the right answer. Now, pulse ox, I saw some of you mark pulse ox. It is a component of the newborn screen, but it's more for screening those congenital heart defects. It's not for screening congenital hypothyroidism. So you were right, pulse ox is part of that newborn screening, but not for what they were asking for that congenital hypothyroidism. Some people also get a little bit thrown off by that thyroid ultrasound. Well, I think, well, we're looking at congenital hypothyroidism, so we must be getting an ultrasound. Remember, this is a screening. So we're not going to be getting a thyroid ultrasound on everyone. It's really when it's going to be diagnosed congenital hypothyroidism based on that screening, that blood test, then we're going to get that thyroid ultrasound. So they really wanted to hear what we can do to screen for it. And then hearing screening is also a component of that newborn screening, but remember that's for hearing loss. Again, we want to catch any issues early, so we do screen in that newborn phase for hearing loss. And that is to make sure that baby can hear sound so they can mimic sound. That's really important in cognitive and language development. Awesome. Okay, let's go to the next one. I'll go to the next poll if you guys read faster than I do. So, which of the following causes the majority of hypothyroidism in our geriatric patients? Is it A, autoimmune thyroiditis, B, post-surgical, C, post-radioiodine, or D, secondary thyroiditis? What do you guys think in our geriatric population? What is going to be the most common cause of hypothyroidism? I see a few responses coming in. Okay, universally, you guys got it right. Awesome job, you guys. Absolutely. Autoimmune thyroiditis. This one I think also can tend to throw some people off because we think of autoimmune more caught a little bit earlier, but absolutely the most common cause that Hashimoto's of our thyroiditis in even our geriatric patient population. Awesome job, you guys. All right. So jumping on to hyperthyroidism. So we have time for our case study. So hyperthyroidism, let's revisit that negative feedback loop. That's what we call it. So again, remember that thyroid gland is going to be releasing the thyroid hormones, T3 and T4. That signals back to the pituitary gland. How much TSH do we need to release? In hyperthyroidism, when there's a lot of thyroid hormone, so there's an excessive amount of T4 and T3, what ends up happening is we get suppressed or low levels of TSH because the brain is seeing all of that in the bloodstream and saying, hey, thyroid gland, we do not need to stimulate you. You need to cool it. So the thyroid stimulating hormone levels are going to be low or suppressed. So again, with hyperthyroidism, it's that overproduction of the thyroid hormone leading to low levels of TSH. Again, we have two different types. We have primary and secondary. What do you guys think is the most common cause of primary? We're going to go into that next poll. But what do you guys think is the most common cause? And I've put the top two here. Is it Graves or toxic multinodular goiter? What is the most common cause of hyperthyroidism in the Western Hemisphere? No, I see a couple of responses. We're not sure. That's good. I love that you guys are trying it. You can always change your response. Think about it. Oh, we're neck and neck now. Anybody else want to weigh in before? Oh, all right. Graves' disease is winning. Is it the right answer? Oh, we're getting more responses. What do you guys think? What do you guys think? Graves' disease is winning. Is it the most common? Yes, absolutely. So you guys got it right. Very good. I love to see that in the polls going neck and neck. But yes, Graves' disease is going to be the most common cause of hyperthyroidism in that Western hemisphere. This is an autoimmune disorder and it causes an overproduction of that thyroid hormone. Remember, it's a primary hyperthyroidism, so it's primarily happening in the thyroid gland itself. And this really leads to an increased metabolic and hyperadrenergic state in the patient. So we see a lot of these universal signs and symptoms: anxiety, irritability, depression, maybe some heat intolerance, maybe some cardiac issues. We see some tachycardia, right? Maybe some shortness of breath from the tachycardia. Certainly some weight loss and loose stools. We see it affecting the GI system as well. And that fatigue, the body's just exhausted, right? In that hyperadrenergic state. Now, what are some signs and symptoms specific to Graves'? And I'm going to launch that next poll. And this one's an open text. So what do you guys think? What are some specific signs and symptoms to Graves'? Any brave souls want to try it? Remember, this is all anonymous, so I can't see who writes what. And I want you guys to try. Let's think about it. Good. We're seeing some labs, so we're seeing the overproduction of the hormones. Good. But what are some signs and symptoms in our patients that are specific to Graves'? And I see tachycardia and I see the exophthalmos, the eye bulging. I know I always get the spelling wrong. It's okay. Weight loss is universal. Awesome. But what I was looking for was that exophthalmos and that eye bulging. Awesome. Awesome job, you guys. What are some other classic signs and symptoms of Graves? What do you guys think? Yes, that heat intolerance. Absolutely. What else? What else makes you think Graves? That weight loss. Very good. Yeah, you guys hit the nail on the head. And I see some more typing, loose stools. Heart palpitations, absolutely with the heart palpitations. I would say that's pretty classic of Graves as well. Textbook, all hyperthyroid, really you get those palpitations, heat intolerance, weight loss, tachycardia. Graves, and I see some more typing. Yeah, anxiety, sexual dysfunction. Very good, you guys. You guys can keep typing. I'm going to keep talking, but you guys are on the money. So absolutely with Graves, we really see that exophthalmos or that eye disease, right? And we also usually see a diffuse goiter. So what's a goiter? That's when that thyroid gland is really swollen, right? And diffuse means it's swollen all the way through. So both lobes, the isthmus, it's all really inflamed, right? And we see that in thyroiditis, especially in Graves. So absolutely. We also see a rash, that pre-tibial myxedema. It's more rare, but you might see some patients with Graves also exhibiting a rash in those lower extremities as well. So again, Graves is going to be the most common type in the Western Hemisphere cause of hyperthyroidism. We have some other types too. So we have those multinodular goiters, solitary toxic not thyroid nodules. We'll talk about that mostly. They're benign, but we do need to work these up. We also have transient thyroiditis. Sometimes it could be triggered by an infection. Sometimes we don't even know it's idiopathic. We don't know what the trigger is, but it could be transient thyroiditis that causes it. And then metastatic thyroid carcinoma as well. And that's why we definitely want to work up those nodules when we feel them. You can also have secondary causes. Again, it's outside of the thyroid due to pituitary issues. We talked about the signs and symptoms. Diagnosis, you're going to be ordering the same labs. You're going to be ordering that thyroid panel, and we're really going to be looking at that TSH and free T3 and T4. That's going to be the best way to diagnose it. If you're feeling really confident with that exophthalmos and you're like, you know what, this is Graves, I'm going to order the thyroid antibodies, go ahead and order those thyroid antibodies. Remember, this is a condition that's going to be managed by endocrinology. You do need to get them over to endocrinology to really talk about their treatment options, and we'll go over those 3 treatment options. But absolutely, if you want to go ahead and get the jump on those antibodies, you can throw it into your thyroid panel. Now let's talk about treatment. You've diagnosed it. This is hyperthyroidism. What are we going to do? First and foremost, we really want to help patients with those symptoms. Remember, they're in that hyperadrenergic state. They're really anxious, sweaty, palpitations. We're going to get them on a beta blocker, and we're going to go really slow with this. Some patients will not tolerate beta blockers. If they don't, we could try calcium channel blockers, but we really want to get their heart rate back down. The 3 definitive treatments for hyperthyroidism that you should be aware of that you probably will have to counsel your patient on while they are waiting to see the specialist are first and foremost, we can start them on the anti-thyroid drugs. That is within our wheelhouse in primary care, and you most likely will be the one starting them on the anti-thyroid drugs and the beta blocker while they're waiting to see the specialist. So our first choice, first line is going to be methimazole unless what? Unless they're pregnant, right? And I'm going to highlight that if you have a patient where you are diagnosing hyperthyroidism and they're pregnant, that is going to be pick up the phone. That's when you make friends with the endocrinologist in your community, and you're going to be consulting and getting that patient into endocrinology right away and talking to the endocrinologist about what we're going to do. What trimester is this patient in, and what are we going to start them on that? But this is something that is a safety precaution around pharmacology, so something that may pop up on the boards. You would not be starting your patient on methimazole if they're in that first trimester pregnancy. You would likely start them on PTU, and then that's going to have to change as they hit that second and third trimester. But anti-thyroid drugs are one treatment option for hyperthyroidism. Something else that the endocrinologist will really have to weigh in on once they've done their evaluation is this patient going to be a good candidate for radioactive iodine therapy? And that's when they really kill that thyroid tissue altogether, and then they'll have to get treatment lifelong for hypothyroidism, or maybe even a thyroidectomy, right? Either a partial or complete thyroidectomy to really then again, have that patient become primary hypothyroid, but treated for hypothyroid for lifelong. So these are really things that the endocrinology team and the surgical team will discuss with the patient. The patient will weigh in, they'll go down one of these treatment paths, and then you may be co-managing this patient as their primary care clinician. So it's good for you to know about. And again, with that pharmacology, you likely will be starting these patients on the pharmacology while they're waiting to see the specialist. But a referral to endocrinology, absolutely, we want to do that. Also, a referral to the eye doctor. So we want to, even if we're not seeing that exophthalmos, we want to be asking questions like, can they close their eyelids? I want you to have them close their eyelids in the clinic, right? And see if their eyelids close all the way, because we're going to be looking for dry eye and other eye issues related to their hyperthyroidism. And they do need to go in to see ophthalmology so they can do more specific testing for the eye to rule out any thyroid eye disease. But of course, if we're seeing any of those urgent signs or symptoms, visual impairment, signs or symptoms of arrhythmias, heart failure, any of that, those are more acute things that need to be worked up on the inpatient side until we can get things under control. So before we move on to our QBIT questions, I want to make sure I take a moment to talk about thyroid nodules. Remember, we talked about this as being a potential cause of that hyperthyroidism. What about other thyroid nodules? So say you're doing a physical exam. I remember my first year of practice doing my head to toe physical exam, patient felt fine, no issues, and I felt a thyroid nodule. So what do we do in that scenario? Well, these are very common. In about half of our patient population, 50%, you will identify a thyroid nodule incidentally. And you have to know that you cannot just ignore it, right? So most of the time, the majority of these cases are benign. And they are found incidentally. I remember in that case, it was benign, it was incidental, but we do need to work it up to make sure they're not malignant, right? And we need to track the growth. So it's really important to go ahead and order that thyroid panel. And depending on your clinical setting, you can order that thyroid ultrasound or send them over to endocrinology to work up that thyroid nodule, and they'll do the ultrasound and see if they find any other, is this multinodular or is it solitary nodule? Right? But we do need to work it up with that thyroid panel and that ultrasound to make sure it's not malignant. That's really important. Recently, I had a patient who established care and she was like, no, everything's fine. Nothing notable in her history. I get to my physical and I always palpate the thyroid, and sure enough, huge, solid thyroid nodule on, actually, I think it was her left lobe. And so I start asking her questions about swallowing, and sure enough, the history starts to unfold. Yes, I saw endocrinology at some point. And so patients will also try to hide things from you. So you really have to be a good investigator and do a thorough history as well as a thorough exam and really feel those thyroids. And you'll get more comfortable with identifying nodules as you feel more and more thyroids. And we talked about the potential interventions, but really this is going to be something that endocrinology needs to work up, and then they'll talk to them about what that intervention looks like. But I wanted to make sure we took a minute to talk about thyroid nodules. Thyroid storm is another one that you may or may not see. This is pretty rare presentation, but it is an acute presentation and about 8 to 25% mortality rate if we don't intervene early. So I want to make sure you're aware of this. This is when the effects of the excess thyroid hormone on the body have been magnified. So different triggers, stress can be a trigger. That stress can come in the form of maybe a recent surgery, a trauma, infection, childbirth, but that can really trigger this hyperadrenergic state. And what ends up happening is patients come in really sick. They could be febrile, tachycardic, sweating, and this is really an emergency. We need to make sure we intervene early to make sure we help that patient and lower that mortality rate, right? So prompt intervention is really important. Oftentimes, I will see this in my patients who have hyperthyroidism and they're on antithyroid medications and they've discontinued it abruptly because I don't know why. For some reason, I'm sure there's some study out there about why hyperthyroid patients do this, but I think they just get really tired of taking that medicine and they stop it abruptly thinking they feel fine, and then they get into this hyperadrenergic state. So typically I'll see it with that. You can also maybe see it with too much thyroid hormone. So another thing I want to make sure you guys were aware of is With hypothyroidism, remember that medicine is weight dependent. So if you have patients who are actively trying to lose weight, maybe they're on a GLP-1 for weight loss, that's all the fad now. You definitely want to make sure you're counseling your patients that if they are actively trying to lose weight, to come in and talk to you about it and make sure you can monitor them so that you can start adjusting their medication so they're not being over-treated, right? I've also seen that in clinic. So you just have to be really careful about that, about why we're seeing patients in this hyperadrenergic state. Is it too much or too little thyroid hormone, or poor medication management on their end? All right, let's go to the next poll. And again, I'm going to go to the next poll in case you guys read a little faster than I do. You can go ahead and answer, but we're going to read it together on the slide. All right, so a 32-year-old patient presents to the NP's office with complaints of unintended weight loss over the last 2 months, palpitations, thinning hair, and insomnia. As she's speaking with the NP, they note that her eyes seem to protrude as pictured below. So anytime they give you a picture like this, pay attention to it. It's a good clue. So again, they're telling you this patient's coming in, 32-year-old, saying they've lost weight, they haven't intended to, they don't feel great, palpitations, thinning hair, sleep issues, and you're noting these eyes. So they're giving you all those signs and symptoms. Vital signs, your medical assistant took the vitals, 128/88. We may want to check that again. But look at that heart rate. We also definitely want to check that heart rate again. 114, if that's right, what should it be? Should it be 114 at resting? No, right? So already I'm getting a good clinical picture here, right? Respiratory rate, temperature, all that seems fine. What diagnostic test does the NP consider to further assess these symptoms? So they've given you signs and symptoms. I want you to practice picturing it in your head when they give you signs and symptoms like that so that you can really picture the case. This patient's in front of you in your clinic. What are you thinking? What is at the top of your list of differentials? Are you going to be getting a thyroid panel, an EKG, a chem panel, or are you going to be doing hormonal testing on our young 32-year-old? What do you guys think? Let's see what you said in the poll. All right, I see a couple people have already weighed in. What do you guys think? Are we getting that thyroid panel, EKG? Remember, her heart rate is up. She's experiencing palpitations. Blood pressure's a little bit high. She's talking about unintended weight loss, thinning hair, sleep issues. What are we thinking? What are we going to check on this patient? I see a couple more weighing in. All right, I couldn't trick anyone. Good job, you guys. Absolutely. We're thinking Graves on at the top of our list of differentials. You might be getting an EKG on this patient as well. You're probably also going to throw in a chem panel when you're ordering those labs. But really what this question was trying to get at is you should be thinking Graves with this exophthalmos and these signs and symptoms coming in. Now, the hormone testing, I think that's a conversation for a different day. I see people going down this rabbit hole with hormone testing. Remember, she's 32 years old. Let's start with the obvious stuff first, right? We're not thinking she's menopausal or perimenopausal at 32. Let's think about the obvious signs and symptoms. This is probably thyroid dysfunction that we need to treat. We don't need to go down this rabbit hole of hormone testing with her estrogen levels and their testosterone. Please don't do that. All right, let's go to the next poll. And I think this one's all fit in my Slido so we can read it together. All right. So what medication for the treatment of hyperthyroidism is contraindicated in the first trimester of pregnancy? Is it A, B, C, or D? I may have hit the nail on the head on this one, but I really want to make sure around safety precautions we talk about this. And you guys know that as you're studying pharmacology, you're really thinking about contraindications as well, right? Because we want to be safe providers out there. Yes. Looks like you guys are all getting it right. That methimazole is contraindicated in that first trimester. It is a gray area though, because then, again, this is something that OB and endocrinology will have to weigh in on, but they might go back on that methimazole in that second and third trimester, right? It really depends on the clinical case by case scenario. But in that first trimester, absolutely contraindicated. Very good, you guys. All right. So before we jump into our case study, if you guys enjoyed what we did in terms of content, but you just need a little bit more deep dive, or you want to keep practicing, our Q Bank has a nice free trial on it, so you can continue to practice based on body systems, based on topics that you want. You can click the unused questions, and you have a full week trial on that. If you like it, you can always purchase the full 1,600 questions. We have a readiness predictor, but it's a really great tool to use as you're studying for your boards exam, which some of you are getting ready to. So that's exciting. We also have on-demand videos that go really in depth into different content areas, especially endocrine and cardiology. So if you need a companion to the Q Bank, you're like, you know what, I need to revisit these topics. I need more on this. Visit the on-demand videos as well. We actually have some really great clinical skills videos in our on-demand videos now. I'm getting ready to advertise that or market that on our YouTube channel, but they are done by our chief nursing officer, who's also a board certified nurse practitioner, and they are great. And I wish I had that when I was in school, because you're always Googling clinical skills, and you want to make sure the source is correct, because there are definitely some things out there that are not correct. So these are really high quality clinical skills videos that are also on our on-demand page, which I really like. So I wanted to make sure you guys knew about that resource. And then we talked a little bit about the SurePass this morning on live, but for those of you who weren't on live with us, SurePass is a pass guarantee, which is awesome, meaning that if you don't pass your boards, then you will either get your money back or come back to us and we'll remediate and make sure you do pass your boards a second time. We get a lot of students coming from other products who come to us who have not passed and then pass with our SurePass, which is really nice. But what it does is it groups all this stuff in together, that Q Bank, the on-demand videos, and our live review. So we have our next live review coming up in May, which is peak season, usually for graduation and people taking boards in June. So if you want to join us for that live review and you want to kind of bundle it all together, it's a really great deal. SurePass Pro, so we have SurePass and SurePass Pro. SurePass Pro gives you that mentoring session, and so you could do mentoring with myself or Brittany or Morgan, and we're all seasoned nurse practitioners who've gone through this, and we're creating this content for you, and we can teach it to you one-on-one if that's something that you would enjoy and need. We'd love to do that for you. Also, make sure you join our Facebook community and group. If you are watching this through the YouTube channel, make sure you request to join the Facebook group. It is private, but we post all of our free content on there, so you can go back and watch everything. And anytime when something is free, especially with all this stuff with sticker prices for NP school and sitting for your boards and licensures, all of that, you really want to make sure you utilize the high quality free content. So just join our Facebook group and you'll get all of that there as well. And then you can always email us if you have any questions. All right, I want to make sure we get to our case study. So here is our sweet friend, Jane Doe. She's a 45-year-old female coming into our office. We've got her measurements and we see that she's a little bit overweight. Otherwise, she's doing fairly well, has medical history of hypertension, nothing really more notable than that. Family history, you've filled all that in. You've had those conversations with her. You are an astute provider and you know that she's got a family history of hypothyroidism. Her lifestyle, you've talked about it. She's mostly sedentary, tries to occasionally exercise, but she admits she's not good with the exercise. Diet's not great. She does work as an office manager and she is pretty stressed out most days. Chief complaint. So she comes in today, she's complaining, I'm really tired. Could be the stress of work, but I'm also noticing that I'm having difficulty losing weight. Yes, I'm not exercising, but she's coming in saying that I can't seem to lose weight, I'm really tired. And she's also noticed some dry skin and thinning hair. And so she's a little bit worried about what's going on. She also reports, as you're asking more questions, because you remember you want to also be checking mood, right, for thyroid function. She also reports mild depression and difficulty concentrating at work. So I want you to keep that in the back of your mind as we're talking about Jane. Current medications, she's just on lisinopril and vitals are pretty normal. So blood pressure is well controlled on that 10 milligrams once a day. You do your physical on her. You do note that she is a little overweight. You do note some dry, coarse skin. You do your thyroid exam, right? And you're noting that that thyroid is symmetric, equal rise and fall. When she swallows, you're going to ask her to swallow as you're palpating that thyroid to feel for that equal rise and fall. Again, looking for those nodules. You're not feeling any nodules, and her swallowing is intact. Heart rate's good. Lungs are clear. She's alert and oriented. No acute distress, but you did go ahead and get a PHQ-9 on her, and we have a score of 5. So we do see some mild depression signs and symptoms. So now I'm going to launch our open text poll. Let's see. But tell me, what are we thinking? What are our initial thoughts for Jane? What are some initial thoughts? Like, what is at the top of our list of differentials? Where do we want to take this exam with Jane? Do we want to order some labs? Do we want to go ahead and start treatment of something right away? Do we need more history here? What are we thinking for our friend Jane? Order labs, beautiful. And if you guys are saying order labs, put in the open text what labs you'd order. And I see somebody's already typing thyroid panel. Good. What else would we be thinking about with Jane? What would we be ordering? Yeah, that thyroid panel includes a TSH and the free T3 and T4. In some clinics, you might have to order it individually just for cost, but absolutely we want to get the TSH, free T3, free T4. And I see someone put in that TPO antibody. That's great, because what did we see in her family history, you guys? Her mom has hypothyroidism, right? And she's coming in with those signs and symptoms. You guys want to get more history. What history questions do you want to know? So put that in here. So we got some labs. Awesome job, you guys. So overall, very good. We're thinking, let's make sure this is not thyroid dysfunction, right? So absolutely. So you guys ordered the right labs. You were thinking clearly. That's awesome. So we're going to get that TSH, free T3 and free T4 and the TPO antibodies. And we know that, yep, her TSH is elevated, right? Also, her free T4, we do see that that's low, but that free T3 is normal. And remember, you will see that because with that conversion of T4 to T3, oftentimes the T3 levels will still be normal while you see some lower levels of T4 and that elevated level of TSH. And her antibodies are positive. So once we get that positive TPO antibody, you don't need to keep checking the antibody. I even see some physicians doing this. So once that antibody is positive, you can go ahead and put it in the chart as this is Hashimoto's thyroiditis with positive TPO antibodies, right? And so absolutely, guys, we're thinking this is Hashimoto's. And we also went ahead and ordered her routine labs just because we want to make sure we're ruling out any anemia with that fatigue, right? And getting a chem panel, making sure her kidney function, electrolytes, all that looked good. She was due for her lipid panel, so we threw that in. And then also looking at her vitamins too, making sure this is not really severe low vitamin D. Most people will have that vitamin D deficiency. And also if you wanted to, you could throw in that B12. That one's kind of questionable. I would also make sure we're asking patients about what they're taking over the counter because I see a lot of interaction with that biotin and their thyroid medication and their thyroid lab. So oftentimes it can mask the thyroid dysfunction. It could look like normal thyroid levels, and it's because of that, the B12 that they're taking. So be mindful of that. All right, so what medications do we want to start her on based on those labs, you guys? Let's see the next poll. What would you prescribe? And so with a few minutes left, and I apologize, I get a little bit chatty, huh? So what would you guys prescribe? Remember, when you're first entering clinical practice, I remember I was like, oh, I can prescribe now. And that was scary to do. So I want you to think it through. What are you going to prescribe for her and put it in here? Let's get a little practice with that. But it's always scary sending in your first couple of prescriptions and thinking like, oh, that went to the pharmacy. I remember that. Yep, levothyroxine. Yeah, and spelling's okay. And so I see some people writing Synthroid. So how much levothyroxine or Synthroid would you prescribe for her? What are we going to start her on? You guys can just write Levo. That's okay. And while you guys are thinking about it, I just want to stress that Synthroid generic levothyroxine is very expensive. So please brand is very expensive. Please start them on the generic. And if patients, sometimes you'll get like labile thyroid levels, they may need the brand, and then you can talk to mail-in pharmacies and see what you can get with their prescription coverage. But you always want to start them on the generic, and that's levothyroxine, 25 micrograms. I love it. Yes. All right. So you guys all started on levothyroxine, 25 micrograms. What are you going to counsel her on with this medication before I go to the next slide and show you guys? So absolutely, we're starting her on levothyroxine, 25 micrograms. What are we going to counsel her on with this medication? Very nice. Avoid the iron Tums. Yeah. And what about taking it on the empty stomach? So you want to definitely talk to her about how to take this medication, and then you want to talk to her about what we're going to do. So it's not just prescribing a medication, letting her kind of go out there. We're going to have her come back in about 6 to 8 weeks and have her do a thyroid panel about 2 to 3 days before, so you can revisit that and look at it together, right? And make sure that we're making small adjustments to get her to the right thyroid medication. So I said 50 micrograms. You guys feel more comfortable with 25, that's okay. But you can also start as high as 50 micrograms. That's okay, and start slowly titrating up. So remember, we're also going to counsel her on signs and symptoms of hyperthyroidism, so she can be aware of that. We talked about the lifestyle a little bit. If she's losing weight, she needs to tell us. If she starts becoming more physically active, which is great, and actively trying to lose weight, that's all really great. It's going to help with the mood as well. We do want her letting us know so we can monitor her a little bit more closely, and also educate her on those signs and symptoms so she can come back and if she's not feeling great, if she's being overtreated. And then we want to make sure we're watching those depression symptoms, right? Was the depression due to the thyroid dysfunction? Is that getting better? Or do we then also need to address the depression symptoms as we're working through all of this? So awesome job, you guys. With that, I'm mindful of the time. It is 12:30 on the clock. So I want to make sure if you have to hop off, you can. If you want to hang back for a few minutes, you also can. I'm going to launch our fun little Slidos about how did you like the Slido polls today? And you can give me a rating on that from 1 to 10. And then I also want to know, what other topics would you guys like to see in these free webinars? So I'm going to jump to the next one on that. And this is a free text. So if you guys want to hang around and tell me what topics you'd like to see in these future free webinars, I'd love to hear that, because we do really listen and make it sure it's student-driven product. And so next month, we are going to have a lot of webinars based on content that you guys have told us you want from past webinars. So if there's anything that you're interested in, go ahead and put that into the Slido. Otherwise, remember to check out that QBank with that free trial. That's going to be really, really fun and important, because it is a free resource and a really nice way to practice some of this content and identify areas that you need to go back and review. And make sure that you also follow us on our Facebook page so that you can get all this free content as well. So I see some people are writing respiratory conditions as a potential topic, which is great. We definitely have respiratory coming up next month, which is wonderful. Anything else for those of you still on today? What do you guys want to see in these live free webinars? Especially for those of you getting ready for your boards. Maybe some test anxiety, maybe some professional development webinars. What are you guys thinking? EKGs, professional issues, very good. All right, well, all things that are definitely on the calendar for March. So make sure, if you haven't already, you follow us, you join our community, follow all of our free content, and also check out our Sure Pass if you're getting ready for your boards. Thank you so much for joining me today, you guys. You guys were an awesome audience, and I will see you next time. Have a great day. Have a great rest of your day.